This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology and training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi, this is Jeff Ratliff with the Neurology Podcast. For this month's Neurology Recall for the month of November, we'll be bringing you 5 topics on the topic of acute stroke management. The first interview you'll hear will be from November 7, 2022, between Dan Ackerman and Imogene Scott, discussing the pre-hospital evaluation of stroke, specifically comparing EMS versus telemedicine. The second interview will be from January 26, 2023, again between Dan Ackerman and this time with David Seiffge, discussing IV thrombolysis of patients with ischemic stroke who had recently ingested direct oral anticoagulants. The third interview in this episode will be from April 27, 2023 of the podcast between Andy Sutherland and Alejandro Rabinstein and Hassan Kobeissi. This interview discussed CT perfusion versus non-contrast CT for late window thrombectomy in acute stroke. The fourth interview is from the July 13, 2023 episode of the podcast, again with Dan Ackerman, with Thanh Nguyen discussing dual antiplatelet therapy versus TNK for patients with non-disabling acute stroke. The final episode aired June 26, 2023, and was a discussion between Andy Sutherland and Seemant Chaturvedi about pivotal stroke trials from the European Stroke Organization Conference. We hope this episode will keep you up to speed on all that's new in the world of acute stroke management. Thanks for listening. We'll see you next month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome to the Neurology Podcast. This is Dan Ackerman from St. Luke's University Health Network in Bethlehem, Pennsylvania, and today I have the pleasure of talking with Imogene Scott from the Department of Neurology at Wellington Hospital in Wellington, New Zealand, about her paper titled Pre-Hospital Telestroke versus Paramedic Scores to Accurately Identify Stroke Reperfusion Candidates, a Cluster Randomized Controlled Trial. Imogene, welcome to the podcast, and thank you so much for talking to us today.
Thanks so much, Dan. It's great to be here and have the opportunity to discuss the study.
I have to say that I was really excited to read this paper and to look at this trial. It really harkens back, in my mind, to some of the prior studies that were done, even looking at neuroprotection. For example, the FAST-MAG trial that, while it did not prove a neuroprotectant agent, it did show the feasibility of doing amazing work like this, where we can really study pre-hospital care of the stroke patient and evaluate some excellent best practices that can happen long before the person even reaches the emergency room. So, Imogene, let's jump right in, and could you describe for us the evaluation that you guys performed and what you learned about looking at patients pre-hospital who may be having a stroke?
We conducted a cluster randomized controlled trial in our region, which is Wellington in New Zealand, and we were comparing telestroke assessment of potential stroke patients inside the ambulance to the use of the PASTA score alongside our standard ambulance protocol. So the PASTA score is quite similar to the Los Angeles Motor Scale, which some of the listeners may be familiar with, which is a score looking for large vessel occlusion of the anterior circulation. And the PASTA version of the score has been used for several years in some parts of New Zealand, which is why we chose that. So different ambulances in our region were randomized to either perform pre-hospital telestroke or to do a PASTA score. So one ambulance acted as one cluster, and we had 6 ambulances in each arm. And so our aim was to compare the diagnostic accuracy of telestroke assessment in the ambulance to PASTA or LAMS, and to see if performing pre-hospital telestroke was actually feasible as well, because in some previous pilot studies of pre-hospital telestroke, there have been barriers such as Wi-Fi connectivity. So we wanted to make sure it was actually technically feasible. And fortunately it was, and we found that pre-hospital telestroke was also more accurate than the PASTA score at predicting predicting patients who were candidates for any reperfusion therapy, which was our primary outcome. So we saw, compared to the emergency room diagnosis, telestroke was 100% accurate and PASTA was just over 70% accurate, which was a very significant difference. And we also saw significant differences in the rate of predicting thrombectomy and the need for thrombolysis treatment. Again, all these differences were significant. And so what we found really was that pre-hospital telestroke was actually very nearly as good as in-person assessment in the emergency room. So we could say that you didn't really lose any information by performing a virtual neurological assessment before the patient arrived in hospital. So this could offer really a significant time saving in treatment of the patient. And we found that our intervention was pretty feasible once we addressed a few barriers, and it was acceptable to the neurologist on our service anyway.
Just to make sure I understand this right, so pre-hospital, you had two groups of 6 ambulances, one group doing the PASTA score, the other group engaged in a pre-hospital telestroke evaluation, and then compared those two in terms of the accuracy of predicting who would be a candidate for some type of reperfusion therapy, whether we're talking about systemic thrombolysis or thrombectomy. Is that right?
Yeah, that's correct.
And just so that we understand, is the PASTA score considered to be a stroke severity score or a stroke screening tool, or a mix of both?
It's really a mix of both, but predominantly looking for stroke severity and for those patients who will be candidates for thrombectomy. So yes, it's really for thrombectomy screening. So if you compare it to the Los Angeles Motor Scale, the additional things that PASTA has, it looks at whether the patient has significant disability, and it looks for mimics like hypoglycemia or the presence of seizure. That would be a rule out for thrombectomy.
Now, a lot of emergency transport services now have some type of stroke screening tool they may use, and they may add a stroke severity score on top of it, or they may use some kind of a combined tool. And that serves both to triage patients, but also may actually inform routing practices. Again, just rehash for us, how does your pre-hospital telestroke evaluation compare to some of those other scores and tools?
The standard practice in our region is that we have a service called Wellington Free Ambulance with paramedics that are trained to respond to a variety of medical emergencies. And they have a manual or handbook which details how they should respond to such emergencies. So when they pick up a patient with new neurological symptoms, they are taught to ask if this could be a stroke. So they would typically perform a FAST score and check for posterior circulation symptoms such as ataxia, among other parts of their checklist. And then on top of that, so we had them do the PASTA score, which I kind of explained includes the Los Angeles Motor Scale, and part of that PASTA score is that the Los Angeles Motor Scale must be greater than or equal to 3, as well as having other thrombectomy rule-out criteria. So that was the process in our region. And then in the other ambulances that didn't do the PASTA score, they would still do a FAST score, check for posterior circulation symptoms to try and include any potential stroke patients. And then if they did think there was significant risk that the patient was having a stroke, then they would contact the hospital, who would dial through to the on-call neurologist, and they would have a telestroke assessment.
And the result of that telestroke assessment from the paper sounds like it was much more consistent with the actual practice once the patient reached the hospital and was evaluated in person by both emergency room staff and by neurologists. And typically, with very few exceptions, it was not the same neurologist that performed the telestroke evaluation. Is that right?
Yeah, and it was important to us to make that distinction so that we could really assess the accuracy of the pre-hospital assessment. So, yeah, the neurologist who dialed in to perform the pre-hospital telestroke was not the same one who assessed the patient in person in the emergency room.
Now, I know from doing telestroke and teleneurology evaluations, which of course we do so much more now after the COVID pandemic or concurrent with the COVID pandemic, it really does take a lot of training at the originating site where the patient is in order to have a nurse, an advanced practice provider, someone who is skilled enough to assist with that evaluation. Talk to me about the training that your team did with the Wellington Free Ambulance Corps and Do you feel like that made a solid difference in their ability to assist with the exam? How effective was it?
We're not 100% certain about that. We did create a video which showed how they should assist with things like visual field testing, limb ataxia testing, sensory neglect testing, and the video was promoted to the paramedics and available to them throughout the study period. But we're not certain that all of them actually reviewed it closely, and some of the assessments were done with paramedics who are probably a bit unfamiliar with the techniques. These are not typically things they would practice. It wasn't too hard to teach them these sorts of things on the spot, but on those occasions, prior skill almost certainly helps the assessment a lot. And so we would encourage some kind of teaching for the paramedics. Also, our paramedics will respond to a variety of medical emergencies, with stroke being only a small part of their work. So some of them may have had less experience with stroke patients.
Now, I appreciated so much also that you mentioned some of the challenges in earlier telestroke studies, particularly related to infrastructure and wireless internet access and the like. And certainly we have listeners in all different parts of the world with varying degrees of internet access available sort of in the general community. So in your study, was that often limited by technology? And if so, how? And what was the kind of access that everyone had for this?
We were very fortunate, actually, because we had access to a 4G connection, and so we didn't have any issues with Wi-Fi connectivity. I know that in some other studies using a 3G connection, the speed of data transfer was not quite sufficient. So yes, some regions might struggle if they don't have access to 4G or even 5G. We did have one limitation with the sound quality early on in our study, but we were able to use a headset, and that rectified our background noise issues.
Is there some way that you evaluated the wireless connectivity in the region where the Wellington Ambulance Corps served, or was that something that was just a find it as you go kind of a principle?
Yeah, I think it was more the find it as you go principle. If we had encountered issues, then we might have had to really think hard about what else we could do or modify the study in some way. But we were just putting it out there and seeing how things went.
Yeah, there's really not a specific internet access level or internet speed that I've ever heard of that is a prerequisite. It's really left up to the clinical judgment of the provider in terms of can they see what they need to see, and can they see it in a way that is quick and reliable so that the communication can be real time and clinically appropriate.
So that was actually an important aspect of our study design, was because we didn't know how that side of things was going to go. Our study was designed as primarily a diagnostic accuracy study. So we weren't intending to change management because of factors like that. We couldn't be sure what risk we would be exposing people to if we were performing the telestroke assessment as part of their care.
That really leads me to one of the other things I wanted to touch on. Before this program was put into place, was this pre-hospital evaluation, particularly the PASTA score, used to change destination or to dictate EMS destination when they had a stroke patient on board? And if not, do you think something like this telestroke evaluation could or should have an impact on the initial destination when you have a patient with a suspected stroke in a pre-hospital setting?
We weren't originally using PASTA in our region, but as I said, it is used in other parts of New Zealand, such as Auckland, and it is a part there of making their disposition decisions in terms of where the ambulance will take the patient. They also contact the on-call neurologist, so it's not only reliant on the PASTA score. But yes, in terms of the second part of your question, whether we think pre-hospital telestroke should change destination, I think it could. That is what we found, that the pre-hospital evaluation was highly accurate compared to in-person evaluation. And so recently in New Zealand, a national pre-hospital stroke committee endorsed a pathway change where teleambulance can be used to assist with bypass decisions, as we do now have good evidence that using telestroke can be very helpful in selecting suitable patients for bypass to thrombectomy centres in particular.
Over the last several years, when we've talked about developing regional systems of care, it's a recommendation that I think is welcome and super appropriate. But at the time the recommendation was made, there really was not a specific way to develop a regional system of care that made sense. There wasn't an algorithm that could be followed or some specific set of instructions. And studies like this where we can look at not only the impact in a region and in a hospital system, but what happens in terms of resource utilization, time for the neurologists that are actually helping with the pre-hospital evaluation, and all of these other factors, and understanding how it plays into stroke care in an area really helps, I think, people to see if their area is a place where it makes sense for a program like this, as opposed to a mobile stroke unit or a trip to treat paradigm the way they have in certain big cities where transport time for a patient is really challenging versus many others. There's so many permutations of this that looking at a system like this and seeing how well it really worked is really going to be helpful as people look to implement best practices in their area.
Every region is so different, and the more research we can get in this area, the more sort of avenues different centres will have to explore as to what strategies will work best in their particular region with their resources and their geography.
Now, after this study itself had been complete, my understanding is you guys implemented this as part of your routine practice now. Is that right?
It is becoming part of our routine care. I don't know if it's fully up and running again yet, but yes, it will be part of our routine care, and we hope to publish some more data once that is available.
Well, of course, without having been there during the study itself, a lot of people may have questions or thoughts about how challenging this was for the neurologists themselves and for the people participating at the hospital, but having to jump into a telestroke evaluation at a moment's notice like that. And I think that the fact that you've decided to continue with that practice beyond the study itself is very telling in terms of this being something reasonable and appropriate that the neurologists have found value in.
I think it's just important to resource your department appropriately and make sure you have the time set aside for this evaluation. It was an extra time cost to the neurologist doing this study because we did have somebody different doing the pre-hospital telestroke versus assessing the patient in person. But of course, once this becomes part of practice, then that distinction won't exist. So hopefully it shouldn't add too much workload to the average neurologist. But yeah, it is important to take that into account. And also, I think it was a bit easier for our neurologists as they already do regional telestroke for other hospitals. So they're familiar with the concept of telestroke and virtual assessment. They just hadn't done it in the ambulance before.
Well, I think we've all had times when we receive the report from, say, an emergency room team or later on from an admitting team, and we really wish we had the opportunity to speak directly with the paramedics in that early setting. So I think this will bridge that gap really nicely.
Yeah.
So were there downstream differences that you've noticed so far in things like door-to-treatment times, either when we're talking about systemic thrombolysis or door-to-needle times, that I know was not a part of the study per se, but just things anecdotally that your team has made note of?
I can't say as yet that we have noticed any effects in daughter treatment times. Our study wasn't powered to assess that as well, so we don't have any data on that, but watch this space.
From your standpoint, what do you think is the most important lesson that the average practicing neurologist can learn from your study?
We've seen in the literature that mobile stroke units have gained increasing recognition and in some regards could be considered, a gold standard for pre-hospital stroke diagnosis and treatment, but it's not always feasible. And in those regions where it's not feasible to implement a mobile stroke unit, I think pre-hospital telestroke, which can also be called a mini MSU, is very feasible. It's less resource intensive and it still can be highly accurate in assessing stroke patients. So we really encourage other centres to consider this approach, particularly if they already have telestroke experience, and we'd really like to see more research in this area.
It's been such a pleasure talking with you today, Imogene. Thank you so much again for joining us today on the podcast. Again, it's been our privilege to hear from Imogene Scott about her paper titled Pre-Hospital Telestroke versus Paramedic Scores to Accurately Identify Stroke Reperfusion Candidates, a cluster randomized controlled trial, which is available in this week's issue of the journal Neurology. Hello, Neurology Podcast. This is Dan Ackerman from St. Luke's University Health Network in Bethlehem, Pennsylvania. And today I have the pleasure of talking with David Seiffge, who is a professor of neurology and stroke neurologist at Inselspital University Hospital in Bern, Switzerland. He has brought us some really exciting titles in the past, like timing of anticoagulation after recent ischemic stroke in patients with atrial fibrillation, ischemic stroke despite oral anticoagulation therapy in patients with atrial fibrillation, and practical 1, 2, 3, 4 day rule for starting direct oral anticoagulants after ischemic stroke with atrial fibrillation, combined hospital-based cohort study. Today, however, David is joining us to discuss a new paper titled Intravenous Thrombolysis in Patients with Ischemic Stroke and Recent Ingestion of Direct Oral Anticoagulants, which was published in the January 3rd edition of JAMA Neurology. David, welcome to the podcast.
Thank you, Dan.
Well, David, this is such an exciting paper and such an important topic, and clearly you've spent a long time studying anticoagulation in stroke. A lot of us will remember in the U.S. back in 2015 when the FDA applied the physician labeling rule to systemic thrombolysis with alteplase or Activase for acute ischemic stroke. And a lot of the contraindications that we had traditionally gone with for that treatment suddenly changed. In particular, the question of whether patients receiving direct oral anticoagulants were at increased risk for hemorrhagic complications when treated with systemic thrombolysis for ischemic stroke is one that has remained even for the last 8 years since that change. And I'm just really excited for the opportunity to chat with you about that. So tell me, how did you design this study and what did you find?
This is a study that we actually arose from friendship, to be honest, and from clinical interest. So we are pursuing this topic since the really beginning. We started using thrombolytic therapy in patients on DOACs already some years ago. And then we were actually interested to see whether this is a systematic question which also others are pursuing, and therefore arose a friendship to many of the lead authors of this paper. And we realized that there is some data out there, but actually the most important subgroup of patients, those with a recent ingestion of a DOAC, have been poorly studied because this information was mainly not available in the majority of studies. So we contacted lead authors of large IV thrombolysis data banks and invited them to contribute in this study. And actually, we managed to include data from 64 stroke centers across Europe, Asia, and Australia, including also a large contribution from New Zealand. So it was virtually a global study. And what we did is we included more than 32,000 patients who received thrombolytic therapy. And we divided these patients into two groups. So the first group were patients who had a known DOAC ingestion within the last 48 hours, which is the critical time span where we actually fear that there might be an increased risk of bleeding. And we compared them with about 32,000 patients who received IV thrombolytic therapy for ischemic stroke, but who were not on a direct oral anticoagulant. And our main question was about the bleeding risk, the risk of symptomatic intracranial bleeding after thrombolytic therapy.
It's amazing that this collaboration just grew so organically out of having a question and talking with friends and colleagues and maintaining those connections. Just to make sure I understand this right, so it looks like your cohort was a total of 33,207 patients. And of that group in those 64 centers, 832 of those patients had exposure to a direct oral anticoagulant within 48 hours of receiving systemic thrombolysis for acute ischemic stroke. Is that right?
That's right, yeah.
So don't keep me in suspense. Tell me, what did you find?
We compared the risk of symptomatic intracranial hemorrhage, which was measured on follow-up imaging after 48 hours of receiving intravenous thrombolytic therapy. And in the overall cohort, there were about 4.1% of patients who actually had asymptomatic intracranial bleeding. And this was the same comparison cohort of those patients not on direct oral anticoagulants. We were actually surprised to see that the rate of symptomatic intracranial hemorrhage was numerically even lower in patients with a recent DOAC intake, with a rate of 2.5%. So the rate of intracranial bleeding was lower in those patients with a recent DOAC intake. And then, of course, we performed a multivariate regression analysis because we had to adjust for differences in baseline characteristics because this was not a randomized controlled trial. And of course, you may expect there were a lot of baseline characteristics which differed between both cohorts. Mainly patients who were taking a DOAC were older, had more comorbidities, more often atrial fibrillation, had a higher stroke severity measured with the NIHSS, but also longer treatment delays to receive thrombolytic therapy, and we had to adjust for it. And after adjusting these crude symptomatic ICH rates, the adjusted odds ratio for symptomatic ICH was 0.57, which was statistically significantly lower than in the comparison group.
So patients who had been exposed to a DOAC actually were found to have a lower risk of intracerebral hemorrhage, in spite of having several risk factors that would be expected to predispose them to hemorrhagic complications such as older age and higher stroke severity. And then after controlling for those risk factors, of course, the odds ratio remains statistically significant. And just to ask, do we have any thoughts about why those patients or this group might have had a lower bleed risk? It's a little bit counterintuitive.
When we did the study, we expected the odds ratio to be just neutral. We expected to find the result that the risk of symptomatic ICH is probably the same in patients on DOAC as on patients without a recent DOAC injection. We are actually intrigued by the finding of a lower bleeding risk. To be honest, we don't have the answer on this question, but we have some theories. So there are two main points which might be important. The first point is that probably the combination of anticoagulation with intravenous thrombolysis might actually facilitate recanalization. So the clot may recanalize earlier, may recanalize faster, so we have a smaller stroke lesion size and infarcted brain tissue, which is then susceptible for bleeding, which might then decrease the bleeding risk. The other point is probably that all these drugs, all DOACs, actually work as direct or indirect thrombin inhibitors. And one of the main drivers of bleeding after intravenous thrombolysis is the blood-brain barrier breakdown, which is also mediated by a thrombin flush. And probably these direct oral anticoagulants somehow counterbalance this thrombin flush. By this, preserve the blood-brain barrier and decrease the risk of bleeding. But actually, this is a theory, and we don't have a proof for this.
Wow, that's really interesting. And I think there are some valid theories there. In looking at your paper and just in our conversation, did I hear you right that there's actually some in vitro data that is a precedent for this kind of finding, which I, for one, was not familiar with prior to meeting you?
Yeah, that's why it's true. So when we started thinking about using thrombolytic therapy in patients on DOACs, we went back to literature, and there have been rodent models of IV thrombolysis in rats, comparing different types of anticoagulants. You will find data on rats who received warfarin, rats who received DOACs, and then thrombolytic therapy. And you can consistently increase the risk of bleeding in rats on warfarin who receive intravenous thrombolysis. But for all DOACs, we have rodent model data which actually show that there is no increased risk of bleeding, even in rats who have DOAC levels or have got so many high DOAC levels in their blood, which actually are 2 to 10 times higher what we expect in humans. So there seems to be also a in vitro proof of this concept.
Now, I'm actually glad you brought up DOAC levels. One of the really elegant things about your paper, I thought you did such a great job of addressing some of the differences in thrombolytic therapy and practice across the landscape of stroke when we look worldwide at so many different centers. In particular, I really appreciate that you included both 2 doses of alteplase and the standard dose of tenecteplase. And actually, there were some differences in the way these patients who had DOAC exposures were evaluated for thrombolysis or for thrombolysis safety as they presented with ischemic stroke. Could you comment on how the exposure cohort was divided, and if that difference in evaluation made any difference in outcome?
When we did our systematic review a few years ago, we realized that people are treating patients on DOAC with IV thrombolytics, but they used different selection criteria. And we divided these selection criteria into three groups. The first group is people are using reversal agents for DOACs to revert anticoagulation prior to IV thrombolytic therapy. This is mostly used for Pradaxa or dabigatran, which is a direct thrombin inhibitor, and you have idarucizumab, a reversal agent available for this drug, and a lot of people are using idarucizumab prior to IV thrombolytics in patients on dabigatran. There is a second selection model which is actually used in countries where the factor Xa inhibitors have a large market share, so apixaban, rivaroxaban, or edoxaban, because you can actually measure these drug levels in the blood of patients, and then you can define thresholds of a low anticoagulation activity and then select patients who are at low activity for thrombolytic therapy. This approach is quite popular in Switzerland, but also in some other European countries like Germany or France. And we were actually surprised to see that there is a third group of people who actually neither use reversal agents nor use DOAC plasma levels to select their DOAC patients for thrombolytic therapy, which give thrombolytic therapy in selected patients. Then, because we were aware of this different selection methods applied and we knew that they are used in different countries in different ways, we actually pre-planned to perform sensitivity analysis of the DOAC patients according to these selection criteria. And we were quite astonished to see that the overall result of a reduced or decreased risk of bleeding holds true also for all these type of selection criteria. There was not one which was superior to the others.
Okay, so 3 separate groups. One group got reversal most often with idarucizumab. A second group was selected based on the anticoagulant activity level on a serum test. And the third group was just treated with systemic thrombolysis, either with the knowledge that someone had received a direct oral anticoagulant within the last 48 hours, or where that information was not available at the time of evaluation and then came to light afterwards. And in all 3 cases, you saw a similar safety profile?
Exactly. So we saw the same safety profile. And triggered by this finding, we actually thought about whether all these kind of selection criteria are really necessary. So what we did then was a post-hoc sensitivity analysis where we actually selected patients with a very recent intake of a DOAC, so where we knew that they had taken the DOAC within the last 12 hours. So we would expect these patients to have a significant anticoagulant activity in the blood, or patients beyond these 12 hours, but with measured plasma levels of a significant level beyond 100 nanograms per milliliter, who were not reverted, who didn't receive any reversal treatment. So this was a subgroup of patients with a moderate to severe anticoagulant activity in the blood. Of course, this subgroup was small, somehow a bit more than 100 patients, but also the overall result of a lower risk of bleeding holds also true for this subgroup, which was actually a very large surprise for us.
Wow, it sounds like you guys really took a very comprehensive approach to looking at this data and pulling everything out of it that you could, thinking about this very clinically, applying it to the patients that we see from day to day. Your secondary outcomes were also very interesting. In addition to looking at intracerebral hemorrhage, which of course is among the most feared complications, you also looked at functional outcome, rate of death, and a few other things. Can you just comment on those a little bit and let us know what you found with regard to exposure to DOACs versus patients who did not have that exposure?
So the main reason why people fear to use intravenous thrombolytics in patients on DOAC is actually the risk of bleeding. And so this is why we choose symptomatic ICH as the main outcome of our study, because the main issue with it was probably the risk of intracranial hemorrhage. But of course, what we would like to achieve with intravenous thrombolysis is improving patients' outcome at 90 days, measured with the modified ranking scale score. So our secondary endpoint was actually the functional independence at 90 days measured with the modified ranking scale score. And the aim was actually to see that the benefits of intravenous thrombolysis, improving outcome after 90 days, would also be true for patients on DOACs. And we didn't find any statistically significant difference between patients on DOACs or patients without DOACs in terms of functional outcome, which means that the benefits of intravenous thrombolysis in terms of improving outcome seems to be the same for patients on DOAC compared to patients without recent DOAC intake.
So, in addition to having an appropriate safety profile, it seems that based on this data, patients appear to have similar benefit from systemic thrombolysis and no increased risk of death or disability for those patients that are receiving DOACs. Is that right?
That's true, yes.
That's really interesting considering the baseline differences in characteristics between groups, that patients who did have DOAC exposure were generally older and had more severe strokes at baseline. Of course, we can't necessarily extrapolate that this shows there was some additional benefit beyond what we would have expected, not based on observational data, but it's an interesting thought.
I definitely agree. So one of the things we frequently countered when we also presented this data at last year's European Stroke Organization conference was that there is probably a selection bias among patients on DOACs who received intravenous thrombolytic therapy, so that people may choose patients that are most suitable for this treatment. But if we look into the baseline characteristics of those patients who received IV thrombolytic with a recent DOAC intake, all these were patients who were severely affected, had a median NIHSS score of 11, so a high NIHSS score, which were older, 79 years old, and had longer treatment delays. So these patients are, if you just look on the characteristics, doesn't seem to be the best candidates in terms of low bleeding risk. But still, we see the same benefit of thrombolytic therapy after 90 days in these patients, which is really reassuring, I think.
Very reassuring indeed. And it really speaks to the principle we always talk about: treat the patient, not the numbers, and look at each patient and their potential as an individual based on the best data and our understanding of the physiology and pathophysiology. So what's the bottom line in your mind? Should the use of DOACs within the last 48 hours be removed from the list of contraindications at this point? And if not, what do you think the next steps are?
I think that the contraindication of a recent DOAC ingestion for thrombolytic therapy should be transformed from an absolute contraindication to a relative contraindication, as we did it with vitamin K antagonist and dual antiplatelet therapy, or, for example, seizures at onset for thrombolytic therapy in the past. We are doing randomized controlled trials for many different questions in medicine and in stroke medicine especially, and I think they are the most valuable contribution to evidence-based medicine. But there are also some settings where randomized controlled trials are very difficult to perform and where we probably may invest money or may invest funding and time in other projects which are more valuable. We have thought about whether a randomized controlled trials of patients on DOACs to receive IV thrombolytics or not would be the next step. And honestly, I think this is something will be very, very difficult to perform. You have to have in mind that patients with large vessel occlusion will receive thrombectomy. So the overall benefit of thrombolytic therapy will be in such a trial much lower than what we have seen in ECAS 3 or other thrombolytic trials in the past. And such a trial would need to recruit more than 6,000 patients. So having in mind that other contraindications for thrombolytic therapy have been softened based on retrospective data like ours, I expect that future guidelines will probably tune down the statement on recent DOAC intake and make it a relative contraindication. The next step of our collaboration now is that we are now going to monitor the use of IV thrombolytics in DOAC patients after the publication of our study. And for this purpose, we have initiated a new collaboration, which is called DOIT, DOAC Intravenous Thrombolysis International Consortium, where we actually going to prospectively enroll these patients in a prospective registry to monitor the use of intravenous thrombolysis in patients on DOACs with recent intake, to actually see whether what we have seen from this retrospective study also holds true in a prospective study. And I would like to invite all listeners of this podcast, if you're interested in contributing to this collaboration, you may just contact me. And we will need all types of centers with a liberal policy on thrombolytic therapy in DOAC patients, but also other centers which may be more cautious and probably do not use thrombolytic therapy that often in patients on DOAC. So we need all type of centers to contribute, and you are warmly invited to contribute if you're interested in an international academic collaboration.
Thank you for that answer and for that invitation. This is a wonderful opportunity to be able to collaborate. And as we know from your cohort, even for centers in whom it is not particularly their policy to offer systemic thrombolysis for people with recent exposure to direct oral anticoagulants, it happens due to the need for speed when treating acute ischemic stroke and at times the incompleteness of data. So, David, thank you so much for talking with us today. I know we have the upcoming International Stroke Conference followed by the American Academy of Neurology annual conference over the course of the next few months. I really hope that this paper and this podcast generates some great buzz and opportunity for people to collaborate, discuss, and consider these options for treatment of our stroke patients. You mentioned in the paper that 1 patient in 6 who would otherwise qualify for systemic thrombolysis is actually on a direct oral anticoagulant medication. So this is not a rare question that needs to be answered only occasionally. This is something that we need to address systematically and to have ready answers available when we treat these folks.
Thank you very much. Really agree with you.
Once again, we've been talking with David Seiffge on his paper titled Intravenous Thrombolysis in Patients with Ischemic Stroke and Recent Ingestion of Direct Oral Anticoagulants. We would recommend everyone to take a look at the original paper from the January 3rd, 2023 edition of JAMA Neurology. David, thanks again.
Dan, thank you very much.
Hello, everyone. This is Andy Sutherland from the University of Virginia. And for this week's Neurology podcast, I have the pleasure of speaking with Hassan Kobeissi and Alejandro Rabinstein from the Mayo Clinic. We're going to be discussing an article published in this week's issue of Neurology titled Computed Tomography Perfusion versus Non-Contrast Computed Tomography for Late Window Stroke Thrombectomy, a systematic review and meta-analysis. In this study, Hassan and Alejandro and their co-authors performed a review and meta-analysis of studies looking at late window, otherwise known as time window of 6 to 24 hours from last known well, for endovascular stroke therapy for large vessel occlusion, acute ischemic stroke, and specifically looked at studies comparing patients who received CT perfusion imaging or multimodal CT perfusion imaging versus non-contrast head CT or CT angiogram to determine treatment eligibility. The method and availability of head imaging prior to endovascular stroke therapy for those who practice stroke and for those who don't has been a topic of increasing interest in the field. There have been some recent trials and publications suggesting that patients may benefit regardless of the degree of infarcted tissue prior to treatment. And so the nature of the type of imaging that we do and that we require prior to treatment is on everyone's mind. So this is a timely article. And Hassan, Alejandro, thank you for joining us for the podcast.
Our pleasure.
Thank you for having us.
And then, Hassan, I think this first question is for you, just to kind of summarize from the get-go for the audience. What were the major findings from this review and meta-analysis that you all did?
We performed a systematic review and meta-analysis of large vessel occlusion stroke in the late window, which is 6 to 24 hours. And we ultimately ended up including 5 studies with 3,384 patients. And in these studies, patients were imaged with either CT perfusion imaging or non-contrast CT to determine eligibility for endovascular intervention. What we found is that for our primary outcome of functional independence, patients that were selected with CT perfusion and non-contrast CT actually achieved functional independence at similar rates. For our secondary outcomes, we found similarly that symptomatic intracranial hemorrhage was comparable between the 2 imaging modalities. However, we found that patients imaged with CT perfusion achieved a higher rate of successful reperfusion, and similarly, they achieved a lower rate of mortality. So overall, we found that the primary outcome was similar between patients that were selected with CT perfusion and non-contrast CT. We found that patients selected with CT perfusion actually achieved higher rates of successful reperfusion and lower rates of mortality. Now, we also extracted the baseline characteristics of patients included in our 5 studies, and we found that the frequency of male sex and female sex was similar between the 2 groups. The amount of patients that received intravenous thrombolysis was similar between the two groups, and the baseline stroke severity was similar between the two groups. Now, of note, patients that were imaged with CT perfusion actually had a greater onset to puncture time by 45.6 minutes. And this was the only baseline difference that we found between the two imaging modalities for selecting patients.
Well, I guess to that last point, Hassan, that's probably not to be unexpected that the folks receiving the CT perfusion imaging would require more time, have a longer aortic groin puncture time for their endovascular treatment, which you all discussed in the paper, of course. But as you noted, ultimately didn't lead to any differences between the two groups and functional outcome. We're going to talk about the larger implications of these results here in a moment. But before that, anytime one does a retrospective review of studies or meta-analysis, there are always possible sources of bias or issues with generalizability. Did you encounter many of those in the studies you ultimately analyzed? And how did you attempt to mitigate any source of bias?
We actually did encounter some sources of bias, as you alluded to. The chief limitation of our meta-analysis was that we were only able to include 5 studies. Now, the reason we were only able to include 5 studies is because we specifically only included studies that imaged patients with both CT perfusion and non-contrast CT. We did not want to have single-arm studies because that would introduce too much bias to our analysis. Due to the low number of studies, we were unable to perform meta-regression, and therefore we could not test for the effect of individual confounders. Similarly, we did not have access to patient-level data, which also limited our ability to test for certain confounders. Now, something specific to our study and the studies included was that the aspects, which is a measure of the severity of the stroke and the size of the core, was high in our study, meaning that the patients had less affected tissue and smaller cores. The median aspects of studies included in our study was 8. So this could have actually limited the difference in treatment effect, and for future studies, it may be a point of interest to see if they could include patients with lower aspects and larger ischemic cores. A couple other limitations that we had was that one study reported functional independence at a different time than the other studies. 4 studies reported it at 90 days, and one study reported it at 6 months. And one other thing was that we were unable to account for single-phase and multi-phase CT angiography due to inconsistent reporting among the included studies. Now, in order to mitigate these biases, we only included comparative studies, as I mentioned. Every study that we included was deemed to be of high quality and had a low risk of bias, and they were all multi-center studies. Finally, all 5 studies provided all 4 of our outcomes of interest, so we were able to have a decently large sample size of patients.
No, Hassan, I think clearly, having read the article and hopefully, we'll encourage our listeners to as well. I think it's a very sophisticated analysis, and you all did a great job of trying to make sure that there was a high quality to the data that went into the analysis, and your methods were sound to try to account for some of those issues. One thing for our audience, again, many of whom may not practice, acute stroke therapy on a day in, day out basis, the aspect score that you mentioned, which is sort of a score that we use to estimate the degree of infarction or early ischemia on a head CT, did suggest that these were folks that likely had salvageable penumbra in both groups. And so I think that is an important point you make, particularly as with my introduction mentioning some of the trials looking at people with more evidence of early ischemia or infarction prior to treatment. I think that'd be an important group to account for in future analyses, as you've already rightly noted. So let me turn it to your colleague, Alejandro here. So the question on everyone's mind, of course, after this study and with our accumulating data is what should we be recommending for pre-treatment imaging for patients undergoing endovascular therapy for large vessel occlusion stroke? I'm obviously curious what you all are doing and how you may be advising your partner hospitals, particularly those smaller hospitals that are less resourced with the rapid availability of imaging.
This meta-analysis gives us the state of literature on this topic. But one of the things that it points out is that we only have information from registries, some retrospective studies. We do not have a randomized controlled trial comparing the selection of patients for endovascular therapy using only non-contrast CT or CT and CT angiogram versus using CT perfusion. And the trials were conducted on the extended window, this window between 6 and 24 hours since the patient was last known well, included perfusion scans as part of the eligibility criteria. And primarily because that is the way that endovascular therapy was validated to be useful in this time window for these patients with large vessel occlusion, is that we still use, in most cases, we still use CT perfusion. Now, going back in time, I'm sure, Andy, you remember that the idea of CT perfusion was mostly to identify patients who might be at risk for reperfusion injury, hemorrhage, and so forth, if they were recanalized, despite the fact that they were having already large established strokes. Well, based on the results of our meta-analysis, where the functional outcomes were comparable, where the hemorrhage rate was also comparable, that original intention of CT perfusion does not seem to pan out. Similarly, now we have information from large cohort trials, even very late time windows, where again, there seems to be a little bit more safety than we initially thought. And so I think that is the main message. Even if you do not have CT perfusion, if you take a good look at your CT, if you have the CTA, you take a good look at the CTA. In centers who have less technological resources, yet they have the ability to either perform or triage patients to endovascular therapy. Doing it with the non-contrast CT would be a valid, in all likelihood, safe alternative, even if it may result in some patients having futile treatment, because what the CTP will give you is information on salvageable tissue. In our meta-analysis, identify the patients more patients that were able to be successfully reperfused. So in summary, we still tend to use CT perfusion in the 6 to 24-hour window and beyond, but we serve a large community where patients go initially to small centers, and that first selection of, yes, this patient needs to come, we do it with the CT and the CTA. And depending on the case, sometimes we do a CT perfusion on arrival to our hospital before going to the angio suite. Personally, many times I am bypassing that and I'm going directly from the helicopter to the angio suite without obtaining the CT perfusion in between, if I am already convinced based on the clinical information and the radiological information from the CT and the CTA that I think that the patient is a good candidate for endovascular therapy.
Thank you, Alejandro. I think that's very helpful and a good framework, I think, that folks can think about depending on which setting and which aspect of that continuum that they're practicing in. And in most situations, I think we all know inherently that it all depends on the exact relationship between the initial hospital and the ultimate endovascular treatment center, thrombectomy capable center the patient goes to, about the method of imaging and transfer, all with the attempt to expedite treatment. So before we wrap up, as you think about this, what are the remaining gaps? Where does the research taking us? And then any final thoughts you want to share with the audience?
Like with so many other things, ideally, we are going to end up having a randomized control trial comparing candidacy based on CT versus CT perfusion. There is also a whole move using better technology and artificial intelligence to get more out of the plain CT, at least promises to change the way that we use imaging for the evaluation of acute stroke. There may be a day when just getting a CT gives you a wealth of information that already tells you, just with the CT, where there is a large vessel occlusion, how much of an established infarction there is, how much of the salvageable tissue there is, what are the chances even of successful reperfusion, all from the CT. That is perfectly within the realm of imagination at this point, but obviously still something that is a promise that remains to be fulfilled. So at this point, I think that practices, as you well mentioned, need to be adjusted to the local availability of resources. The intention should always be to try to recanalize and reperfuse patients with large vessel occlusions unless there is a clear contraindication because of the powerful beneficial effect of this treatment intervention.
Well, fantastic. Thank you, Alejandro, for those guiding thoughts. And CTP or not to CTP, that remains the question. But I think we're further along in our understanding than we have been, in large part. Thank you to you all for performing this analysis, which I think is helping move the field forward. So again, this has been Andy Sutherland speaking with colleagues Hassan Kobeissi and Alejandro Rabinstein from Mayo Clinic. And I want to encourage all of our listeners, please seek out the full paper published in this week's issue of Neurology, Computed Tomography Perfusion versus Non-Contrast Computed Tomography for Late Window Stroke Thrombectomy, a Systematic Review and Meta-Analysis. Gentlemen, thanks again for joining us for the podcast.
It's been a pleasure.
Thank you for having us.
Hi, and welcome to the Neurology Podcast. This is Dan Ackerman from St. Luke's Health Network, and today I have the pleasure of speaking with Thanh Nguyen from Boston University about her paper titled Dual Antiplatelet Therapy versus Alteplase for Patients with Minor Non-Disabling Acute Ischemic Stroke, the Aramis Randomized Clinical Trial. Thanh, thank you so much for joining us on the podcast today.
Dan, thank you so much for having me. And I also want to acknowledge the principal investigator of the trial, who is Huixing Chen. He was the brainchild behind this Aramis trial.
Wonderful. Well, thank you, Dr. Chen, as well, because this is a great study. Now, there are so many important things in this paper for us to unpack, but one thing I just want to get off the bat, this idea of minor non-disabling stroke. Could you just talk to us a little bit about how you defined minor non-disabling stroke, and how does this affect your clinical practice from day to day?
So minor non-disabling stroke was defined in the Aramis trial as patients who presented with acute ischemic stroke with an NIH stroke scale of 5 or less, and they had to have 1 point or less on the NIH single item scores, such as motor, vision, language, neglect. And you couldn't score in the consciousness item because we were worried that would be a potential stroke mimic or a patient with encephalopathy. So that was excluded. And then the study treatment had to start within 4.5 hours. So if these patients met these criteria, they were automatically considered for the trial. And then in terms of the non-disabling component, that was a little bit trickier because we had to ask the patient or their family, if the patient wasn't able, we had to ask them to what degree would this deficit that they present with might interfere with their activities of daily living, their hobbies, or their work. And so that was a very important component of selecting if patients would be eligible for this trial, because as you know, this is a very controversial population for consideration of alteplase versus other therapies.
Absolutely. I think in our practice from day to day, it's very easy to be pigeonholed a little bit by the NIH stroke scale. And the NIH stroke scale is wonderful as a tool, but recognizing that patients who score 0 on the stroke scale may still be symptomatic, and those symptoms could still have a major impact on their life. Having a method like this to pick out those patients for whom the symptoms would still be disabling in their eyes, and having that open communication about how important the symptoms are to the patient does a great job of really reinforcing that early doctor-patient relationship, since we're trying to deal with this rapid decision-making, and helps us to orient ourselves in terms of alteplase versus other potential therapies. I love that.
And to ride on your point, Dan, even though you could be included with an NIHS of 1 point on the motor scale, so say you had a drift, if that was going to be potentially disabling to the patient, meaning, I need to play violin or I need to play my piano, then they probably would not have been included in the trial.
Now, in this trial, this was a non-inferiority study comparing alteplase versus dual antiplatelet therapy. So tell us about the results. What did the trial teach us?
It pivots on the point that the NINDS trial, the initial trial that demonstrated that TPA was effective in patients presenting within 3 hours, they were excluding patients with rapidly improving or minor strokes. And so this set the bar for who you should treat with TPA or not. And then in 2011, we saw some data coming out from Get With The Guidelines. There was a paper I remember as a resident, Eric Smith and Lee Schwam, looking at these patients with rapidly improving minor strokes, and a significant proportion of them had pretty poor discharges. They didn't do well on discharge criteria from Get With The Guidelines. And so this spurred some interest in looking at these patients in more detail. So we fast forward to the IST trial, the International Stroke Trial, where they compared alteplase versus routine medical management in patients with all kinds of stroke. And then they focused specifically on patients with minor stroke, so NI stroke scale 5 or less. And so Dr. Khatri performed this very nice analysis. And what she found was that in these subgroup of patients where they had minor stroke defined as NIHSS of 5 or less, there seemed to be a treatment benefit of giving alteplase by approximately 9% absolute benefit of getting better outcomes, better excellent outcomes, which in their study was defined by the Oxford Handicap Scale. So they took that equivalent as like the MRS 0 to 1. And some guidelines building on these early data were stating that you could consider giving alteplase to patients with minor non-disabling strokes. So the early 2018, I believe, AHA guidelines and then the Chinese guidelines also said that it can be considered. It wasn't a strong recommendation, however, but it was in the guidelines. So in our psyche, when we're seeing these patients in the ER, we're always asking, when was your last known well and what are your deficits? And so even these patients with minor symptoms, they were being considered for alteplase. So that's why we wanted to see, well, can we compare these patients with dual antiplatelet? And this idea of dual antiplatelet really emerged, as you know, from the POINT and the CHANCE trials, both trials showing that DAPT was better than aspirin alone in these patients with minor ischemic stroke / TIA in reducing the recurrent event rate. So Dr. Chen and colleagues wanted to study this by a non-inferiority design. Well, maybe the dual antiplatelets are not inferior to alteplase, and then we can prove that it's good enough to give these patients DAPT if it was true. And so the findings in this study were that indeed, after enrollment of, I think, 700 patients, we found that dual antiplatelet therapy in these patients was non-inferior to alteplase, and we met the non-inferior border margin on the confidence intervals. And so we exceeded that. And so that's why, in essence, this was a positive study showing that patients overall did quite all right with dual antiplatelet therapy compared to intravenous alteplase if they presented within 4.5 hours. And in terms of the proportions, there were about 93% who had MRS 0 to 1 in the DAPT group, and 91% had MRS 0 to 1 excellent outcomes in the alteplase group. So pretty strong data to show that DAPT is non-inferior. And we weren't seeking a superiority signal. So even though the number was higher in DAPT, I don't think we can say it being superior.
Thank you so much for that background. That's outstanding. It's a real masterclass in reminding us how we got to where we are in current treatment. Okay, so based on this study, we're suggesting that dual antiplatelet therapy with aspirin and clopidogrel is non-inferior to systemic thrombolysis with IV alteplase according to the standard protocol at 0.9 milligrams per kilo, maxing at 90 milligrams. That's right?
Again, this was a study conducted purely in China. So, of course, the question of how transportable are these data outside of China is another big question. And obviously, we can look at the parallels with the CHANCE trial, which came out earlier than the POINT trial. So these were the dual antiplatelet trials. And when CHANCE came out showing that DAPT was superior to single aspirin, then the world was waiting for POINT, meaning they said, we're not going to change our practice because this was in a Chinese population. So let's see what POINT shows. And indeed, POINT showed a very similar pattern. And so the fact that there's some similarities in outcomes between CHANCE and POINT, I think you can potentially speculate that that might be the case for these patients between DAPT and intravenous alteplase. So it's a speculation. It's not hard evidence, but in short of that, it is some evidence that could give you some reassurance as you're making these decisions, seeing these patients in the ER.
Yeah, I really couldn't agree more. I remember when CHANCE came out and sort of waiting for POINT, and then later on we saw THALES coming out. And the fact that those populations are really quite similar to the population in this study would suggest that maybe those concerns over generalizability are not as significant as we originally might have thought them to be. We'll have to see as the data continues to mature, but I think it's a really great point that you made. And speaking of CHANCE and POINT, there was some variability in a post-CHANCE and POINT world with regard to the dual antiplatelet therapy that's chosen. In particular, do you load with 300 versus 600 milligrams of clopidogrel, and typically maintaining that for 3 weeks. In this study, the choice was to load with 300 milligrams of clopidogrel in addition to aspirin, and to maintain that combination for 2 weeks. Why was it organized that way?
This was drawn from the previous data from Chance and Point, obviously. Chance loaded with 300 milligrams and then continued dual antiplatelet versus aspirin for 21 days. And then Point loaded with 600 milligrams. So they went more aggressive on the treatment up front and then went with, I believe it was 3 months of dual antiplatelet versus aspirin. And so in Chance, what we noticed is there was no increase in hemorrhage rates between the dual antiplatelet versus the aspirin group, whereas in Point, there were excess hemorrhages in the DAPT group, not necessarily ascribable to the 600 load, but that's what was observed. And so because there's this signal of potentially higher hemorrhagic risk with this regimen, then we just wanted to keep with the bare minimum, going with the 300 milligram load. And the question is, why would you go with a 600? And the potential answer is because when you go with 600, you get to a therapeutic level faster to being therapeutic on the antiplatelet regimen. But maybe 300 is good enough. So that's why in Aramis, we went with 300. With regards to the question about duration, in the Chance study, they looked at the duration. Do we really need to go out to the 21 days that Chance went out to? And so they did a sub-study in Neurology, and they looked at this, and they found that the turning point was about 10 days, after which the risk-benefit ratio between dual antiplatelet versus single antiplatelet converged. And so that's why in Aramis, we did not want to increase the risk of hemorrhagic events. We wanted to maximize the potential effect of dual antiplatelet. And so we limited this to the 2-week regimen based on that sub-study of the Chance trial.
I really appreciate that insight into the thinking as the trial was being designed. And I think that kind of information is really helpful for how to apply these study results to patients that we're seeing today. With this particular study, did you notice any challenges in the safety arm in comparing the bleed rates of systemic alteplase versus dual antiplatelet therapy?
That's always the greatest concern, is bleeding. That weighs heavily on us every time we give drugs to these patients. And so in terms of symptomatic hemorrhage, which is what we are most concerned about, between alteplase and dual antiplatelet, there was essentially no difference, although numerically there were more event rates in the alteplase arm, so 0.9% of patients had a hemorrhagic event that was symptomatic compared to 0.3%, but still that's not significant. And if you look at any bleeding events, then this was significantly higher actually in the alteplase group, 5%, compared to the dual antiplatelet, which was 1.6%. So that was significantly different in terms of any bleeding events, but for what we were always worried about, the symptomatic hemorrhages, it wasn't different.
Thank you for that. So a little bit as we might expect, there was some excess bleeding in the alteplase group, but not symptomatic hemorrhage. Now, anytime we're talking about acute ischemic stroke, it's important that we remember that there are going to be some patients with stroke mimics in our treatment groups. That's just the nature of the beast. And they say if you have never treated someone with a stroke mimic, you're just not treating enough stroke patients. Do you think that these results inform our treatment of patients, particularly those with stroke mimics, in any particular way? And how was this dealt with in the study, if at all?
Every day, we're always wondering, are we treating a mimic, right? Because we're not getting MRI routinely on these patients because there is no time. So really, your decision to treat is based on the clinical presentation, the history, and the exam. And so inevitably, you will be treating mimics, and I certainly have in my practice. As for Aramis, they included patients based on the clinical presentation, and also there was an imaging criteria of demonstrating ischemic stroke on CT or MRI. And so to what degree patients had either modality, I would have to dissect in the details of the protocol. But suffice to say that in real world, you're not necessarily going to know if you're going to be treating a mimic up front unless it's obvious and they have other medical history, like a prior migraine that's complex. So you may not know that up front. In Aramis, unfortunately, we didn't have a special section for the mimic patients because most of the patients were already confirmed by imaging. When you look at the consort diagram, there were 2 patients that were excluded by the fact that there was no stroke on MRI. So I think this was a very refined population of hard stroke, meaning imaging confirmed stroke. So unfortunately, that was not well addressed in the Aramis trial. Suffice to say, even though it wasn't addressed, what you can think is if you have a potential mimic that exactly meets or mirrors the criteria of Aramis, you might feel reassured that, okay, well, I may not want to go aggressive and give alteplase because of the bleeding risk. But if I give DAPT, I may not be harming the patient either, or taking away a potential benefit of giving them TPA. So you might have some reassurance based on that Aramis trial.
Very reasonable. In particular, sometimes the more so-called minor or less disabling stroke cases are the ones where we're more concerned about mimics. Patients who present with a severe clear stroke syndrome that localizes very well to one area of the brain most often are indeed experiencing a stroke. But at times when we have a little more of that wiggle room in patients who have more mild symptoms that we could attribute to multiple potential causes, well, that's where the mimic population is really centered. So I really appreciated your explanation. I also really liked the secondary endpoints and the subpopulations in this study. And in particular, those patients who presented to the clinical trial group with minor stroke or minor non-disabling stroke, but also large vessel occlusion. Could you comment a little on how that group did in particular and any other subgroups that you feel were particularly important to bring out?
Yes, that was actually a reviewer question, which is great because it's naturally the question that everyone wants to know. So we had to further delve into the data and look at patients who had the data on large artery occlusion. And as you can imagine, because the entry point of these patients are patients with minor stroke, they're not obliged to undergo CTA from the outset in clinical practice because guidelines say you don't have to treat patients less than NIH of 6. So naturally, because of that, we don't have a lot of data represented on the presence of large artery occlusion. I think it was only present in 36 of the 700 patients in the study. And so this is largely underrepresented. And when you look at the confidence intervals, I don't think we can say very much as to whether alteplase or DAPT is better, but that we need more data. Unfortunately, there will be data that's already being studied by the Calgary group. Dr. Sheila Coutts is looking at this via an international trial with Tempo, looking at thrombolysis for these patients with minor stroke and large vessel occlusion. So I think we'll learn a lot more there.
As some of the advanced vascular imaging continues to come into the mainstream, and certainly at many hospitals, that becomes part of that initial stroke evaluation, it's going to be a really important question to continue to address and consider for patients who have minor symptoms, but evidence that they may be at higher risk for worsening compared to your average patient with minor symptoms that does not have a large vessel occlusion. But really that gets down into the nitty-gritty of some very specific patient situations. Thanh, this study was done in China, but of course, stroke is a worldwide problem, and there are huge differences from one country to another with regard to healthcare organization, healthcare resources, and particularly in low and middle income countries, there can be a major impact on someone's care with regard to the cost of treatment. Could you speak a little bit about how this study could be useful in different settings and some of the feedback that you've gotten from people around the world with regard to these results?
What I didn't realize when we released this paper was the reaction from colleagues in lower or middle income countries, where they welcomed this study because of the potential ramifications for patients in terms of cost of treatment, where in some countries, patients do have to pay for alteplase, and it can be a significant cost to them, versus aspirin and clopidogrel, which might be a lot lower cost compared to the intravenous lytic. So in patients where you have that potential controversy or that equipoise where they might meet the Aramis criteria, giving them dual antiplatelet would offer some reassurance that this is a okay treatment to offer these patients, and you're not offering inferior treatment than alteplase because they're presenting with stroke-like symptoms, and that the families could rest assured and the patients could rest assured that the outcomes are likely going to be excellent, whether or not you go on DAPT or on intravenous alteplase, kind of attenuating the intensity of resources of the cost of the drug and the aftercare of these patients in the first 24 hours in an intensive care unit setting or a step-down unit.
When we talk about cost to the patient and to their family, as well as the cost to healthcare in general, it can be much higher with alteplase versus aspirin plus clopidogrel in all sorts of different settings. And because acute ischemic stroke is such a time-sensitive, crucial emergency, it can be very easy to be a little bit more blind to those costs compared to the average neurologists treating patients in other kinds of settings. So keeping that in mind and particularly recognizing the difference from country to country is just really crucial. I think overall, this is a very elegantly done study, and it's really going to help inform our treatment and really is a great next step after Chance and Point and Thales to help us understand the best way to treat patients with minor stroke and minor non-disabling stroke. Anything else that you wanted to bring out and summarize about the study?
Yeah, I just wanted to draw out the fact that when you look at the NIH tiers, grading from 0 to 1 to 3 and 4 to 5 subgroups, there was a bit of a signal for the patients with NIH of 4 or 5, seeing potentially a signal for alteplase being better than dual antiplatelet. So I just wanted to mention caution for these patients where they accumulate NIH points because they may not be as disabling as we think. And so I think this is obviously a moving target and a population we just want to be careful about before we apply our criteria too liberally.
I think this study really helps to drive home the point that it's not a one-size-fits-all kind of approach to stroke care, and that we need to be able to take this data and apply it to each patient as an individual and make sure we understand the stroke symptoms they're experiencing in the context of their lifestyle and what are the potential risks, benefits, and alternatives to systemic thrombolysis in that setting. I really think that this was exceptionally well done. Thank you so much again for talking with us today. Again, we've been discussing the paper titled Dual Antiplatelet Therapy versus Alteplase for Patients with Minor Non-Disabling Acute Ischemic Stroke, the ARAMIS randomized clinical trial, which appeared in the June 2023 issue of JAMA. Thanks so much again.
Thank you, Dan.
Hello, everyone, and thanks for tuning in to this week's Neurology podcast. We have a special podcast for everyone listening out there today. I had the pleasure of interviewing my colleague, Seemant Chaturvedi, who's the director of the Stroke Division and Vice Chair for Strategic Operations at the University of Maryland, Department of Neurology. And Seemant is going to be talking with us about his experience from attending this year's European Stroke Organization Conference, which was held May 24th through the 26th in Munich, Germany. For many of our listeners, you may be familiar with stroke conferences here in the United States and North America, but this particular conference, the European Stroke Organization, has become quite an event, a place to learn about new science, new trial results, growing in prominence over the last few years. And true to form, there was an exciting lineup of new trials in the field of stroke and cerebrovascular disease that were presented at this year's conference. And we wanted to share some highlights from those with you all listening out there today. So first and foremost, Seemant, thanks for joining us for the Neurology podcast.
Yeah, my pleasure, Andy.
So we can't cover it all. There really was a smorgasbord of new science presented at the conference, but I think that we're going to focus on just a few pivotal trials that we're presenting, starting with one in the field of stroke prevention. This is something that should be relevant for all of us, all of our listeners out there who care for patients who have had stroke and who are at risk for having strokes in the future. And the trial I think that we're going to get started with is the Arcadia trial. This is something that many of us were enrolling in the United States, and so we're eager to learn more about this trial at this year's ESOC event. So, Seemant, what can you tell us from what you heard about the Arcadia trial at ESOC?
The Arcadia trial was, I think, a long-awaited trial because there were two previous studies which looked at the concept of ESIS, or embolic stroke of unknown source. And it was hoped in the past that the direct oral anticoagulants, or DOACs, could be useful for patients with an ESIS type of stroke. Unfortunately, two previous trials have been negative, and there was the Navigate ESIS trial looking at rivaroxaban, and then the Respect ESIS trial looking at dabigatran. And both of those failed to show any definite benefit of the direct oral anticoagulant for patients with ESIS type of stroke. Arcadia added a new wrinkle, however, in that it required all the enrolled participants to have evidence of so-called atrial cardiopathy. And this was felt to be disease of the left atrium manifest by either a certain P-wave abnormality on the ECG, or patients could have elevated NT-BNP levels in the blood, or they could have an enlarged left atrium judged by the left atrial index. And so the concept is that if patients have problems with the left atrium or dysfunction, even in the absence of overt atrial fibrillation, they could potentially benefit from anticoagulation. And so Arcadia tested apixaban versus aspirin in these types of patients. And the study was halted prematurely after 1,015 patients had been enrolled, and it was stopped by the Data Monitoring Committee for futility. And at that time, patients had 1.8 years of follow-up, and very uncannily, both groups had the exact same number of recurrent strokes. The apixaban group had 40 recurrent strokes and 40 in the aspirin group. So overall, the annual rate for recurrent strokes was 4.4% in both groups. And so this showed no definite benefit of apixaban in this group of patients with an embolic stroke of unknown source plus evidence of atrial cardiopathy.
This result definitely made its way through the stroke community. I think many were hopeful that we would define another group of patients that we perhaps had a more alternative treatment for than standard antiplatelet therapy, but did not turn out to be so with this hypothesis of atrial cardiopathy and anticoagulation. Sort of thinking about what we've learned from the trial, and I know that we're still waiting on the full data to be published and presented. I know they're doing a number of additional analyses, the level of the trial. Where do you think we go from here, Seemant? Were there any sort of limitations in this trial population that affect our understanding of the trial, or do you think it pretty much answers the question in toto?
In the stroke community, there's been a lot of sort of discussion about whether we should abandon the concept of ESUS because it's so heterogeneous. And maybe from the research standpoint, we should focus more on specific entities and drill down even more on specific entities, and that ESUS may be too big of a grab bag, because patients with ESUS, they could have paroxysmal AFib, they could have clots in the aorta, they could have non-stenotic plaques in the carotids or perhaps in the intracranial circulation, and some may have coagulation abnormalities. And so maybe it's erroneous to think that one antithrombotic agent can address all of these. And so there's been some discussion about whether we should focus more on specific entities like non-stenotic carotid plaques or other conditions. There was also discussion about whether all the biomarkers which were chosen in Arcadia, whether those are all really equal. And because the majority of patients qualified on the basis of the ECG or the BNP levels, and maybe the thresholds which were selected were not adequate to identify a high risk enough population to potentially benefit from anticoagulation. And maybe if we focus more specifically on patients with severely dilated left atrium, maybe those patients could have some potential benefit, as some other sub-studies have shown. And then the other, I think, main conclusion is that we should probably keep our eye on the ball for overt atrial fibrillation, because it seems that this so-called atrial cardiopathy may not be a high enough risk condition, and we should focus more on overt atrial fibrillation, because we know from the public health standpoint there's a long way to go in terms of improving rates of anticoagulation and treatments of patients with overt AF.
That's a good segue to talk about another trial that was presented at this year's ESOC event, and that is a trial that has been published, the early versus later anticoagulation for stroke with atrial fibrillation trial or study, or the ELAN study. And so this trial, I believe the results have been published in the New England Journal of Medicine, coincident with the conference on May 24th, 2023. And Seemant, so this trial, just kind of for our audience, was looking to try to better identify the timing of resuming anticoagulation in patients who have been admitted with stroke and who have atrial fibrillation. And so this is a question we all wrestle with when we admit patients with stroke to the hospital, and many of us use sort of observational experience or our own expert opinion to define this timing, some other patient-related factors. But what did this study show us, and how does it help inform this kind of regular question that we encounter in stroke patients?
This study, I think, is very practical, and it's very relevant to the daily practice of many neurologists who take care of patients in the hospital, because it's a very common reason for consultation, which is the timing of anticoagulation for AFib with a stroke. Andy, in the past, you may recall, in a previous podcast, we discussed the 1-3-6-12 rubric, and that's a tool that I've used in the last several years, which says that if it's a TIA, start the anticoagulation after 1 day. If it's a mild stroke, 3 days, a moderate stroke, 6 days, and for a severe stroke, reevaluate and wait at least 12 days. And so the ELAN trial was sort of using that as the comparator group, but saying that can we sort of nudge the initiation of the anticoagulation a little bit earlier. And so in the early group, the target was to start the direct oral anticoagulant within 48 hours for a mild or moderate stroke, and to start it on day 6 or 7 for a more severe stroke. The caveat is that their definition of mild or moderate was more of a clinical and imaging-based definition compared to the 1-3-6-12 rule, which in the past had relied primarily on the NIH stroke scale. And so what the authors found is that the early initiation did slightly better. And if you look at the recurrent events, they were about 3% with the early initiation compared to 4.1% with the later initiation. Not a huge absolute difference, but in terms of the primary endpoint, which included ischemic stroke, hemorrhagic stroke, systemic embolism, major bleeds, there was a slight reduction in events in the early initiation group. And many clinicians in the past have had concerns about transforming the ischemic stroke into a hemorrhage by the early initiation of anticoagulants. But this study showed that it was very rare and that the hemorrhagic transformation was only about 0.2% in both groups. And so I think that's very reassuring. And that's, I think, likely related to the fact that the DOACs have much less brain hemorrhage in general. But in this study, the rate of hemorrhagic transformation was very low. One caveat, though, is that at the time of randomization, the NIH stroke scale was pretty low in both groups. It was around 3. And so this was really a pretty mild stroke population. And so I think if you have a patient who you're seeing in the hospital with a moderate or severe deficit, it could be prudent to still wait either 6 days or 12 days to begin anticoagulation. But I think the ELAN trial shows that if the patients have mild to moderate deficits, and I would say if the NIH score is like less than 8, then these patients appear relatively safe for early initiation of anticoagulants.
This study is really additive, for all the reasons you pointed out. This is a hard entity to study because it is so dynamic. You're looking at multiple different time points, multiple different ways to estimate the severity of a stroke, the risk of bleeding. But at least this gives us some additional rubric beyond the thumb rule you mentioned earlier, which I do recall from our prior podcast and something I think that I grew up using and being taught as well. So I'm excited to be able to apply these new data for my patients to teach our residents and students the same and feel a little bit more comfortable in starting anticoagulation sooner, particularly with our direct-acting oral anticoagulants in patients with at least minor or moderate strokes or infarct size. So really exciting trial. I encourage listeners to check it out in the full manuscript in New England Journal of Medicine. As we're moving along, we want to cover a couple of additional studies. And since we're talking about risk of intracerebral hemorrhage, we might as well talk about 2 pivotal trials in patients presenting with primary intracerebral hemorrhage. One trial was the INTERACT 3 trial, or the third intensive care bundle with blood pressure reduction in acute cerebral hemorrhage trial. Seemant, what can you tell us about this most recent ICH trial?
This trial was looking at a multifaceted intervention for patients with intracerebral hemorrhage. The main intervention was blood pressure lowering and trying to get the systolic below 140 millimeters. But also the research study included attention to glucose and also prevention of fever and trying to keep the temperature less than 37.5. And also for patients who were on anticoagulants, rapid correction of warfarin and trying to get the INR corrected within 1 hour. As it turned out, very few patients were enrolled with an anticoagulant-related hemorrhage. And so it was really primarily a study of patients with hypertensive hemorrhage. And what the authors found is that with the intensive blood pressure reduction, it was about 7 millimeters lower at 1 hour and 4 millimeters lower at 24 hours. And they found that overall there was improved functional outcome compared to usual care. And the number needed to treat was 35 in patients who received the intensive care bundle. They also had lower mortality of 14% versus 17%. And they also reported benefits in quality of life. And so overall, this population, they were not patients with huge hemorrhages. The median ICH volume was 15 milliliters. But in this population, there did appear to be some modest benefits with the intensive care bundle. And also another interesting finding is that the majority of patients were enrolled from low to middle income countries. And so I think this illustrates that a lot of the elements in the care bundle can be widely applicable.
That last point's, I think, really key, Seemant. Is this something that, folks listening to this, whether they're in a comprehensive stroke center or a community hospital, if they are in a facility that does take care of patients with intracerebral hemorrhage, is this the kind of bundle or care package that most places could implement? It seems like that your answer would be yes, based on where the trial was conducted.
Yes, definitely. And I think as you indicated, if you're at a primary stroke center and you have patients, say, in the medical ICU with an ICH, all of these elements in the care bundle should be usable at your primary stroke center. And so I would recommend that primary stroke centers review this study and try to incorporate some of the practices.
Fantastic. And I should also point out that this trial has also been published in The Lancet, coincident with the European Stroke Organization Conference on May 25th, 23. So folks can check out the INTERACT 3 trial there. The second intracerebral hemorrhage trial that was presented, it was called the ENRICH trial, early minimally invasive removal of ICH. This is yet another trial looking at surgical intervention in intracerebral hemorrhage, an important topic over the years. What did we learn from the ENRICH trial, Seemant?
This, I think, was really a potential breakthrough. And I say potential because it hasn't been published yet, so we need to see the full publication once it is in the literature. But this looked at minimally invasive hematoma evacuation, and the evacuation was very effective. It reduced the ICH size from about 50.5 milliliters to 15 milliliters. And so they reported the median 88% reduction in ICH volume. And the authors reported a 36% reduction in the chance of a poor outcome. And this translated into a number needed to treat of 11 to achieve a modified Rankin score of 2 or less, and number needed to treat of 8 for a modified Rankin score of 3 or less. And in addition, the surgical group had a decreased 30-day mortality of 9.3% versus 18%. The benefit was mostly in lobar hemorrhages, and so they did not see any benefits in deep hypertensive hemorrhages, which is an important point. But I think this is a potential breakthrough which will change practices across North America and the world. But as I said, we need to see the full publication. But I think this could be the first demonstration that surgical intervention and surgical evacuation of a hematoma can be beneficial for patients with an acute ICH.
That is really change-making in the field. That's prior ICH surgery trials, as you pointed out, Seemant, have not been positive. And so this really would give us a foundation to look at some of these very particular ICH patients. It sounds like mostly lobar hemorrhages, easy to approach surgically, and we will look forward to the full manuscript and publication of those results to extrapolate that to practice. Finally, in our quick tour of the waterfront here from ESOC, I know that there's one trial that is near and dear to your heart, or at least the topic, which was the ECST2 trial, the second European carotid surgery trial. Seemant, tell us what we learned from this study looking at carotid stenosis surgery and what it means for practice.
Yeah, I definitely found this exciting because I've had a longstanding interest in extracranial carotid disease. And many listeners may not realize, but the original NACID publication and original ECST were published way back in 1991. And so some of our trainees weren't even born then, but it's been over 30 years. And so in ECST2, they wanted to look at the comparative benefits of revascularization versus modern medical therapy. And they included a combination of asymptomatic patients along with low to moderate risk symptomatic patients. And they reported results at 2 years. And interestingly, they found that the medical patients actually did better at 2 years with a stroke rate of 6.0 compared to 8.1% in the patients who received surgery plus medical therapy. Now, once again, the caveat is that this study hasn't been published yet, and so we'll need to see the full results once it's in the medical literature and it's been fully vetted. But I think this is a noteworthy demonstration that modern medical therapy does appear to be beneficial for patients with carotid disease and even for patients with symptomatic carotid disease. I think medical therapy can potentially reduce the stroke rate by 50 to 70% if you intensively lower LDL and if you use dual antiplatelet therapy and improve blood pressure control compared to the original studies. And I think this study also provides a lot of impetus for North American investigators to finish CREST-2. CREST-2 is looking at 70 to 99% asymptomatic stenosis, and this is an important NIH-sponsored study. And the enrollment is about 90% over, and so hopefully the ECST2 results will provide some fuel for the CREST-2 investigators to finish enrollment so that we can gain information on modern medical therapy versus revascularization for asymptomatic stenosis.
Seemant, I'll add to that plug. This is critical that we complete enrollment in the CREST-2 trial. It is, as you pointed out, predominantly being conducted in North America, and we need to make sure we complete this enrollment and have a fully powered trial to help definitively answer this question or better understand this question of how to manage patients with asymptomatic carotid stenosis. As you noted in ECS2, it was possibly underpowered because of not meeting their full enrollment sample. The patients also perhaps didn't have the same degree of carotid stenosis as we'll see in CREST-2. So this is important. If you're at a place or in a system or near a facility where they are enrolling in the CREST-2 trial, I implore you to please refer your patients with asymptomatic carotid stenosis, severe carotid stenosis, 70 to 99%, to a CREST-2 investigating site. And I suspect can reach out to Dr. Chaturvedi if you have any questions about that, who himself is on the executive committee of that trial and an expert in this category. So very exciting. I think we could continue to talk at length about the variety of trials and studies that were presented at this year's European Stroke Organization Conference, Seemant, but this is a great smattering of really pivotal trials that hopefully will form practice and that people listening to this podcast can go out and apply to their practice as well if they're caring for patients with stroke and cerebrovascular disease. So thank you so much again. I'll refer our listeners, you can check out these plenary highlights and other information about ESOC this year at their 2023 conference website. And we'll put a plug in that if you're looking for a trip to Europe or you are in Europe or anywhere around the world, I think next year's conference is also going to be in May in, I believe, Basel, Switzerland. Seemant, if I'm not mistaken. So go ahead and set your watch for ESOC 2024 in Switzerland, and we will look forward to following up then for even more exciting science in the field of stroke. So, Seemant, any last-minute thoughts or comments?
I just wanted to congratulate the organizers of ESOC for a very stimulating conference, and it sort of covered the whole gamut from acute treatment to prevention to rehab. And the next sort of big conference on the calendar is the World Stroke Congress in Toronto in October. And so hopefully that will provide clinicians additional very practical information and more cutting-edge information to optimally help with stroke prevention and treatment.
Fantastic. There it is. So thanks again to Dr. Chaturvedi and all our listeners. We look forward to talking with you again on a future podcast. Have a great day, everyone.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.